Good morning. It is a great honor and pleasure that I introduce to you Dr. Anna Kostrewsky for her presentation and grand rounds on palliative health and psychiatry. As her psychotherapy supervisor over the past year, I have observed her skill expansion, her embracing new learning from group therapy to aspects of palliative care to volunteering in clinics in West Africa. Anna is an extremely talented person and psychotherapy recipient as well as resident. Anna received her BA at Indiana University in sociology and French, and that probably explains a lot of the diversity and the compassion that she brings to the practice of psychiatry. She followed this by a postdoc or post-baccalaureate pre-medical program at Bryn Mawr College, and followed up with medical school at Rush Medical School of Chicago, and followed by her current residency at the University of Louisville. She has contributed to both her local, national, and international communities through a number of volunteer projects. And without further ado, I'll let Anna introduce her grand rounds.
Thank you so much, Dr. Davis. I'm going to share my screen now. See it. Just loading. All right. So today's topic is palliative care for the psychiatric patient, an emerging field for treatment-resistant mental illness. And as Dr. Davis said, my name is Anna Kostrewsky. I'm a fourth-year psychiatry resident at the University of Louisville, to be finishing up next month. So let's see, no disclosures. This is the CME information. I'll leave it up for just a second if anybody needs this. It's also attached in the email that has the Zoom link. Some learning objectives for today. How to define palliative care in the context of mental illness, to discussing psychiatric disease states that might qualify for palliative care, reviewing current research regarding the attitudes towards psychiatric palliative care. So I'd like to start today's discussion with reading a short excerpt from Sylvia Plath's novel, The Bell Jar. So in this scene, she's speaking with, the character is speaking with a nurse while admitted to an inpatient psychiatry unit for major depressive disorder with psychotic features. And I think it's a really poignant illustration of how managing somatic illnesses can be in some ways more straightforward, but for patients and caregivers, management of psychiatric illnesses can be sometimes much less straightforward. And that dichotomy, I think, segues well into today's discussion. So it reads, "Don't you want to get up today?" No, I huddled down more deeply in the bed and pulled the sheet up over my head. Then I lifted a corner of the sheet and peered out. The nurse was shaking down the thermometer she had just removed from my mouth. "You see, it's normal." I had looked at the thermometer before she came to collect it, the way I always did. "You see, it's normal. What do you keep taking it for?" I wanted to tell her that if only something were wrong with my body, it would be fine. I'd rather have anything wrong with my body than something wrong with my head. But the idea seemed so involved and wearisome that I didn't say anything. I only burrowed down further into the bed. So the central question that we'll be addressing today is, can a psychiatric disorder itself be considered a terminal illness? The agenda for today, we'll start with a clinical vignette. We'll briefly discuss some current events relating to the topic, discuss the concept of futility, try to define palliative care for psychiatry, discuss how we can apply the staging model to psychiatric disease, discuss decision-making capacity, emerging research, and some barriers to this concept. So to start with a vignette, history of presenting illness. This patient, Mr. C, is a 57-year-old male with a history of schizophrenia who presented to EPS, Emergency Psychiatry Services, via EMS. Mother called EMS after patient was wandering near their home. Patient was notably paranoid and disorganized on arrival. Soon after, the patient unexpectedly attacked a pregnant staff member. They required PRN medication and had since been sedated. They were admitted to the inpatient psychiatry unit. The patient was diagnosed with schizophrenia in his mid-20s. Prior to this, the patient didn't have any notable psychiatric issues and had worked several maintenance jobs. He had not been able to work since his first psychotic episode. After the first episode, the patient was stable on monotherapy olanzapine until his mid-50s. And at this age, the patient started developing intermittent catatonic symptoms, fluctuating with aggression. So he has since undergone 7 extended hospitalizations, often requiring transfer to Central State Hospital. During his last hospitalization, the patient underwent 13 bilateral ECT treatments with minimal improvement. Some brief medical and social history. The patient's only medical comorbidities are hypertension managed on amlodipine, no surgical history. The patient lives with his parents who are in their 70s, no history of substance use, no previous arrests. And this is for you, Dr. Caudell. He graduated from KCD and he took regular classes, no trauma history. So the psychiatric hospital course, the patient continued to exhibit random aggressive behaviors despite compliance with the medication. He required PRN medication multiple times a day. The patient began ECT and underwent 9 treatments. He was also started on clozapine, which was titrated up to 800 milligrams daily. On hospital day 25, the patient was found to be unresponsive. A stat response was called and the patient was found to have fever, tachycardia, and elevated CK. He was subsequently transferred to medicine. So the hospital course for the medical unit, the patient continued to be intermittently combative on the medical floor. He necessitated restraints and frequent PRNs. He had extensive medical workup, including an LP, a CT MRI head, and a full body PET scan, all of which were unrevealing. The patient was seen by the psychiatry consult team who suspected agitated catatonia, and he was started on lorazepam, which was titrated up to 25 milligrams total daily. The patient had a poor response and amantadine was added. Still was having a poor response, so the decision was made to resume ECT treatments while on the medical floor. After the first ECT treatment on the medical floor, the patient entered status epilepticus and was subsequently transferred to the neuro ICU. In the neuro ICU hospital course, the patient was trialed on several combinations of antipsychotics and mood stabilizers. Lorazepam continued to be titrated to 36 milligrams total daily. The patient developed respiratory depression and required intubation. He was started on Precedex and lorazepam drip. 3 days later, the patient self-extubated and seemed to have improved, so he was transferred back to inpatient psychiatry. So we'll pick up this vignette in a little bit. So moving on to briefly discussing some current events related to the topic. So you may have heard in the news recently, Canada has been discussing legislation regarding MAID, or medical assistance in dying legislation. So this became legal in Canada in 2016, and it allows terminally ill adults to control their deaths. In March 2021, the bill was expanded to include additional situations that would qualify you for medical assistance in death. And so that included people with disabilities and chronic diseases. So this was a departure from the original concept was when the patient had an impending death, essentially. And in this expansion, it was discussed that patients with severe and persistent mental illness could also be included, which has been very controversial. And of note, this is actually legal in some countries in Europe, notably the Netherlands, Belgium, and Switzerland. However, this was very controversial in Canada, and the clause for severe and persistent mental illness has been postponed several times, first until March 2023, and then it was again postponed to 2024. So basically, there's a recent movement to include mental illness as the sole underlying condition. Oftentimes, patient might have comorbid conditions, but this addresses patients whose only condition for the medical assistance in dying is their psychiatric illness. So here's some of the news articles just to illustrate how pervasive this has been. This is the original from 2016 from the CBC, Liberals assisted dying pills now law after clearing final hurdles. This is an interesting article in the New York Times about a 3D printed pod that would allow people in Switzerland to enter and end their own life. It's not in production, but it kind of illustrates how this is an emerging field. There's been lots of opinion essays on different sides of the issue. This, for example, is in the New York Times in April 2023, written by someone with a history of depression, arguing medical assistance in dying should not exclude mental illness. And many physicians in Canada are very conflicted. This one in particular, Dr. Madeline Lee, has been very outspoken. She's often quoted in many interviews in the BBC, says, "Who can die? Canada wrestles with euthanasia for the mentally ill." And there's a podcast in the New York Times titled First Person Podcast. "They're severely mentally ill. Is it ethical to help them die? A psychiatrist's dilemma when the most extreme option is legal." And then this is most recently in February 2023, the Canadian federal government moves to delay medical assistance in dying for people suffering solely from mental illness. So this brings us to question number one. At what point is it no longer in the patient's best interest to continue to pursue variably morbid treatments without clear possibility of benefit, often outside the scope of typical psychiatric practice? So now we'll discuss the concept of futility as it relates to this topic. So broadly defined, futility means that the treatment being provided is essentially useless or ineffective. And this is a very well-established paradigm in somatic medicine. And if a treatment has no chance of being successful, oftentimes a discussion is made to proceed towards palliative care. So I think most of us are fairly comfortable with that concept, and even culturally, it's a very well understood idea. However, this is a limited and very controversial discussion when it comes to psychiatry. So as I said, this is a longstanding issue in somatic medicine, which I'll refer to as somatic medicine rather than simply medicine, because what we practice is also medicine. So this, for example, is an article from 1990, Medical Futility, Its Meaning and Ethical Implications. However, in psychiatry, there's no true consensus regarding futility. And to date, really only has been discussed regarding anorexia nervosa and dementia. So, for example, here's an article from the American Journal of Bioethics titled "Futility in Chronic Anorexia Nervosa, a Concept Whose Time Has Not Yet Come," discussing the ethics of palliative care for patients with anorexia nervosa. And then likewise, it has been discussed a fair amount regarding decision-making capacity in patients with dementia. Here's an example of an article from the American Journal of Alzheimer's Disease and Other Dementias, Cognitive Fluctuations as a Challenge for the Assessment of Decision-Making Capacity in Patients with Dementia. So In comparison to articles dating back several decades relating to somatic medicine and medical futility, this has really been a rare discussion in the psychiatric field. The first time the terms medical futility and psychiatry were used together in the title of a scientific article was in 2010. So it's this article that was published in the journal, International Journal of Eating Disorders in 2010, titled Medical Futility and Psychiatry, Palliative Care and Hospice Care as a Last Resort in the Treatment of Refractory Anorexia Nervosa. It's a fairly controversial article, but it does lay out several qualities that a patient would need to meet in order to be qualified for palliative care, which we'll discuss in a minute. So how do you define what is futility? Usually it's broken down into two branches. There's quantitative futility and qualitative futility. So quantitative futility, sometimes referred to as physiologic futility. So this is the most objective form of futility. And so it's based on evidence-based medicine. Is that intervention unlikely to benefit the patient? So an example of quantitative futility could be prescribing antibiotics to a patient with a viral illness. On the other hand, there is qualitative futility, which is much more subjective. And this is where a proposed intervention would probably produce such a poor outcome that it's deemed best not to do it. And this is much more of a gray area, and both the patient and the caregiver or provider's value system and own opinions definitely shape it. So an example could be pursuing further rounds of chemotherapy treatment when previous rounds have been, very difficult for the patient and have not proven effective. So the outcome is in some ways deemed worse than not treating. So how do we define medical futility when it comes to psychiatry? So again, referencing this article, which was laid out 4 criteria to determine this. So first of all, the patient has to have a poor prognosis. And this is fairly straightforward. It's patients who are very ill and have a severe mental illness. And then they have to be unresponsive to competent treatment. And this as well is also fairly straightforward. If they have been provided with adequate treatment, adequate length of treatment, et cetera, then you could safely deem them to have met that criteria. So next, they would have to continue to decline both physiologically and psychologically. And this perhaps a little bit more subjective, but really, you can track a patient's disease course and objectively, provide data if in different ways that they might be continuing to decompensate in terms of decreased functionality, et cetera. And then the last criteria that these authors propose is that they appear to face an inexorably terminal course. In somatic medicine, this can be fairly well described for various disease states. But in psychiatric medicine, this is a little bit more difficult to decide. Most of the diseases that we treat may not be terminal in the traditional sense. So this criteria can be definitely up for debate. So to revisit the vignette for Mr. C, so going back to his second psychiatric hospitalization, so he was extubated and doing better in the ICU. He was decided to be transferred back to the inpatient psychiatry unit. He was less aggressive, but he still continued to be paranoid and have disorganized thoughts. However, 2 days later, he became aggressive again, and he appeared similar to his initial presentation, even at the very beginning of the hospitalization, and eventually required transfer back to the ICU. So his transition to palliation. He required interdisciplinary meetings with psychiatry, palliative care, ethics, critical care, and the neurology teams were established. The option of further treatments or transition to comfort care were presented to the patient's parents. The parents opted for comfort care. They declined further interventions with which they felt prolonged the inhumane. His mother signed a DNR/DNI. The patient was continued on standing orders for lorazepam, phenobarbital, valproic acid, and clonidine. Although sedated, the patient appeared calm, and this allowed the patient to be off of restraints. He died several weeks later of cardiac arrest in the context of aspiration pneumonia. So when thinking about this patient and whether or not his case was futile, we can remember several treatments that you might consider a last resort treatment didn't work for him. Oftentimes, clozapine is considered a last resort antipsychotic, but this led to fever, tachycardia, and elevated CK and required a medical transfer. He received bilateral ECT, and he was retrialed on this given his prior response. However, it led to status epilepticus and transferred to the ICU. He was given very high dose benzodiazepines, but this caused disinhibition and respiratory suppression. So when considering the 4 criteria for this patient, did he have a poor prognosis? I think that that's fairly evident that yes, he was suffering from schizophrenia and had not been doing well for several years. So we can consider this to be criteria to be met. And then secondly, was he unresponsive to competent treatment? I would argue yes. He had been receiving care for decades, standard of care, etc. So yes, he did receive competent treatment and he was unresponsive. Did he continue to decline physiologically and psychologically? Yes, I think that's fairly evident. He has required numerous hospitalizations, was not able to work anymore. He was physically aggressive, etc. So yes. However, the final criteria, does he appear to face an inexorably terminal course? You could argue yes, as was the case that was decided for this patient, that his disease course was not to be expected to improve. That brings us to question number 2. What is the current role of palliative care for severe treatment refractory mental illness within the culture of psychiatry? So let's next attempt to define palliative care psychiatry. Before we define palliative care psychiatry, what is palliative care in general? So according to the World Health Organization, they put forth a definition in 2014 stating it's an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So this is quite a broad definition. I think it's interesting that it includes patients' families in the definition of palliative care, and also interesting that it does seem to advocate that psychological, psychosocial, and you could argue psychiatric problems would fit within this model. But here's a diagram that helps kind of visualize the concept of palliative care. So along the x-axis, you have a timeline where the patient receives a diagnosis and then time progresses, starting with the acute illness and then progressing to chronic illness, life-threatening illness, and then death. And then the model continues, which I think references how palliative care is designed for the families and loved ones as well, because it includes this bereavement arm. And then on the y-axis is focus of care. So in this section, you could, this is the therapy to modify disease. So trying to provide treatment to cure the disease. And then in this section here is palliative care. So basically it's saying that it's a continuum, but your focus changes as the patient progresses throughout their disease course. At the beginning, you will almost exclusively focus on treating the disease. As the patient progresses, you might have a blend of both treatment interventions and some palliative care options. And then as the patient becomes more and more ill, heavier disease burden, the level of palliative care would increase. So the question that often comes up, which is an important one, is psychiatry already palliative? And I think lots of people would argue that yes, what we do could already be considered at base palliative care in many ways. So this is a quote from Dr. Trashel. He works out, he's a Swiss psychiatrist based out of Basel. And this is a letter he wrote to the editor of Lancet Psychiatry in 2016. And it's a very referenced letter to the editor, kind of one of the first times that, explicitly discussing palliative psychiatry. And so he says, several clinical approaches in modern psychiatry can already be considered palliative, as they aim at promoting quality of life rather than achieving disease remission or disease modification. And he also says, a palliative approach in psychiatry does not mean giving up on a patient, but rather involves redefining the goals of care. This entails accepting the reality that mental illness can be fatal. So let's discuss next the interplay, the relationship between psychiatry and palliative care. The collaboration between the two fields has been long established, and it's only increasing, especially over the last 2 decades. And typically it will be described with labels such as palliative care psychiatry and psycho-oncology, which is of note, some of the work of Dr. Davis, my supervisor. She's a specialist in this area. And then it can be further broken down into kind of 3 ways, the way that these two fields interact. So first, you could have the somatic palliative patient. So let's say a terminally ill cancer patient develops psychiatric symptoms. Then you could have a mentally ill patient at baseline. They become somatically palliative. And finally, you could have a mentally ill patient who becomes psychiatrically palliative. So the first kind of relationship between the two, this is very well established. There are textbooks written on it. There are many experts in this field. And basically this would be, for example, as I said, a patient with a terminal illness who becomes psychiatrically ill. And this is likely when a consult liaison team might be called. So I think we're fairly comfortable with this form of intersection of the two fields. And then the second way that they could overlap would be if you have a chronically ill psychiatric patient who develops a somatically terminal illness. So let's say your patient with schizophrenia develops, stage 4 renal failure. In this case, the same as you would do for any somatic palliative patient, perhaps you would refer to hospice. And then this is the basis of our discussion. What happens when a psychiatrically ill patient becomes not somatically palliative, but psychiatrically palliative? So this is when palliative psychiatry would enter the picture. So it's not quite at this stage a bidirectional relationship. So in contrast to the well-established inclusion of psychiatry in palliative care, there is to date only marginal inclusion of palliative approaches in psychiatry. So typically it is the psychiatrist providing recommendations and care for patients who are under the traditional palliative care model. However, the palliative care principles are less often directed towards the psychiatric patient. So what are some features of palliative psychiatry? So the first one being focusing on short-term quality of life, and then long-term consequences to certain interventions are given less weight. There is a strong emphasis on respect for autonomy and respect for dignity. And also it's more permissible to have intermittent palliative sedation to control various problematic behaviors. So what are some practical ways that this might be implemented? So what does this really look like on a day-to-day? So these are some ideas I came up with. I'd be interested to hear if anyone else had any other ideas. You could be less concerned for addiction risk, especially comes to mind benzodiazepines. You could prescribe them a little bit more freely without concern that a patient would develop an addiction. You could be a little bit more creative, you could say, in terms of your selection of pharmaceuticals, and you might have increased off-label uses. And there would be a shifting risk-benefit discussion, especially regarding side effects of medications. Something that comes to mind was the checking of ANC for clozapine, which can be quite prohibitive and difficult for many patients. You could potentially prescribe clozapine and in a palliative model decide not to check blood levels on a regular basis. You could also stop checking drug levels and just only treat to clinical response. And then, as I mentioned, you could employ intermittent sedation for increased symptom control. And so what are some possible effects that palliative psychiatry might have? So one could be that a substantial number of patients could benefit who otherwise would run the risk of being neglected or, on the other hand, aggressively overtreated. So you might be able to reach more people and help more people, in this difficult to treat subgroup who might, on the one hand, be neglected or, on the other hand, receive excessive amounts of care. And then a second possible effect could be a change in the goals of care. So similar to what happened in somatic medicine with the establishment of palliative care. A further possible effect could be reduction in treatment discontinuations, because patients see palliative approaches as more adequate to their situation than aggressive treatment. So in some ways, patients may become more compliant if they feel like these palliative approaches are more truly helping them with their comfort level and quality of life, rather than a more traditional treatment that they might not be as interested in. And then the last one is interesting. These authors cited here posit that perhaps there would be fewer actually requests for assisted suicide if more palliative options were available. So if more comfort care measures were available, then perhaps patients would be, not requesting assisted suicide if they're living a more comfortable life. So the next question is, how do you determine who is an appropriate candidate for a palliative model in psychiatry if you want to go about it in an ethical manner? So this decision is twofold, and it involves consideration from both a disease pathology perspective and an ethical perspective. So we'll talk now about the concept of psychiatric disease staging. So I think all of us are quite familiar with the idea of disease staging, especially from the oncology model, where you can, describe, for example, in the TNM system, the tumor size, the lymph node status, and presence or absence of metastases. And this allows for a measure that is more standardized to describe the disease progression. And it improves communication between physicians and also the patients too, to have a standardized description of how they're doing. So is it possible to apply this model to psychiatric diagnoses? Psychiatric pathologies. So here is it's called Staging of Mental Disorders, a Systematic Review. And this is by Kostrewsky and Fava, and they posit that yes, it would be possible. Their model is a four-stage model, stage 1 being the prodromal phase, stage 2, acute manifestations, 3, residual phase, and 4, severe and persistent mental illness. And they delineate how this would look for specific diseases. So for example, staging for schizophrenia, ranging from stage 1 being a prodromal phase with deterioration of functioning, and all the way to stage 4, chronic phase in attenuated or persistent form. So you could say that the patient C from the vignette would have stage 4 schizophrenia, or stage 4 in persistent form. Again, they provide a model for unipolar depression. This is a 5-stage model beginning from prodromal phase. So you could be stage 1B, unipolar depression, where you have mood symptoms, where you're sad, but it doesn't meet the threshold of a major depressive episode. And then all the way on the other extreme, stage 5, chronic major depression. And they also propose levels of treatment resistance of unipolar depression, ranging from stage 0, no history of failure, all the way to stage 4, failure of 3 or more adequate trials involving at least one augmentation or combination or electroconvulsive therapy. So I think this would help really kind of explain how different patients have responded to treatment and the severity of their illness. They also propose a model for staging of anorexia nervosa, stage 1 prodromal being uneasiness and fullness after eating, reduction of food intake, choice of safe foods, and then all the way to stage 4, chronic in attenuated or persistent form, extreme emaciation, laborious exercise, and general debility. So next we'll discuss decision-making capacity. So once you have staged the illness and you've determined that they are sufficiently psychiatrically ill, then the next step would involve assessing their ability to consent to undergo palliative care. And really the assessment of a patient's decision-making capacity is foundational to the ethical delivery or the withdrawal of care. And I think we're all familiar with these 4 major pillars proposed by Applebaum back in 1988 of the 4 criteria necessary to prove that a patient has decision-making capacity, which would be applicable to this discussion as well. So the first is the ability to communicate a choice. The next is to understand the relevant information, to appreciate the situation and its consequences, and to reason about treatment options. But the difficulty with our patient population with severe and persistent mental illness is that the very nature of their disease may render them incapable of satisfying these 4 criteria. So with patient C, for example, he had severe paranoia. Would this have made him suspicious and unwilling to engage in an evaluation? But nevertheless, patients with severe persistent mental illness should be supported to participate in goals of care discussions to the best of their abilities. So how do you preserve patient autonomy despite a debilitating, severe and persistent mental illness? You could have patients appoint surrogate decision makers. This patient's parents came and eventually helped make decisions for him. And patients can create advanced directives. And these goals of care discussions could be held during periods of relative stability when they're doing better and more able to fully participate. So let's now look at some emerging research and data relating to this topic. So Dr. Trashel, who I mentioned earlier, has two interesting studies about psychiatrists in Switzerland, looking at the acceptability of palliative psychiatry among psychiatrists. So this was published in BMC Psychiatry in 2019. It's titled "The Acceptability of Palliative Care Approaches for Patients with Severe and Persistent Mental Illness, a Survey of Psychiatrists in Switzerland," a country where, you know, this topic is much more heavily discussed than in the United States. So this was a survey among 1,311 Swiss psychiatrists, response rate of about 35%, mostly male, 63% male, 57.8 years old on average, and work experience of about 28 years. So they found that in general, this group of psychiatrists agree that for some patients with severe and persistent mental illness, palliative care is indicated. The majority of patients saying they either agree strongly or agree to some level. And then this brings us to another question. Should a palliative model for psychiatry include the option of physician-assisted suicide for select patients? So, you know, this kind of begs the question, what is the difference between these two concepts? So with palliative care, your goals would be quality of life, and you're not either attempting to prolong or shorten the lifetime. Really, you're working on harm reduction. And then on the other hand, physician-assisted dying, the goal is expressly to shorten the lifetime of the patient. The overlap and commonality between these two is the goal is to alleviate suffering and to respect patient autonomy. So this second study, also by Trashel and others, among the same group of psychiatrists, asked them their attitudes toward assisted suicide requests in the context of severe and persistent mental illness. So in Switzerland, this category of patient is eligible for a physician-assisted suicide, although it is fairly rare. And now the answer to this question among the group of psychiatrists is much more divided and leans more heavily towards the disagree end of the spectrum. So the question being, I strongly agree or strongly disagree to the statement, I generally advocate for the access to assisted suicide for patients with severe and persistent mental illness. The majority of patients responding either that they are neutral to this statement or they strongly disagree. And what about in the US? This is a much more rare discussion. It's not something we really think about, especially the idea of physician-assisted suicide. So Dr. Trashel attempted to do a similar survey for US psychiatrists. And it was a quantitative cross-sectional survey among psychiatrists in the US. Sample size of similar, they reached out to 1,300 patients, and these were randomly drawn from an AMA database. However, the response rate was quite low. It was only about 5%, and there were only 60 respondents. Similar demographics though, mean age of 54 and majority male. So definitely underpowered, but I think it can promote some discussions nevertheless. So this is what he shared. I don't have the raw data, but this was from an APA presentation back in 2017 that he gave. And so for the US psychiatrist, he asked how important in the treatment of patients with severe and persistent mental illness is curing the illness, reduction of suffering, function in daily life, the patient's autonomy and decision-making, and impeding suicide. So the majority agreed that function in daily life, actually everybody agreed that that was very important. Also reduction in suffering and impeding suicide. Curing the illness was most likely to be deemed not important. And then they asked, how strongly do you agree or disagree that the term palliative is directly related to end of life? Most people, US psychiatrists agreed to that. Most agree that SPMI can be a terminal illness. The fewest number agreed, about 61% agreed for some SPMI palliative care is indicated, meaning about 40% of the respondents of US psychiatrists did not agree that this was indicated or were neutral. And then finally, in psychiatry, applying a palliative care model is important to provide optimal support for certain patients. Majority agreed with that. And then this is asking about palliative sedation. How strongly do you agree or disagree that sedation for the reduction of unbearable refractory psychological symptoms of the patient is justifiable in certain cases of severe persistent mental illness? Only a little over half of the US psychiatrists agreed with that. And even fewer, which is interesting, said they would be generally willing to perform sedation. So it's interesting that a lot of, or some US psychiatrists said it'd be justifiable, but they wouldn't be comfortable doing it. And then this is asking about US psychiatrists and their opinions in regarding to advocating for the access to assisted suicide for patients with SPMI. The vast majority, over 70%, disagreed with this, and that they would not support patients being referred to another physician, even if they were requesting it. So overall, the US psychiatrists much more against this concept. So in summary of the US findings, the majority of US participants think that severe and persistent mental illness can be a terminal illness. The majority of US participants is in favor of a palliative psychiatry model for these patients, and the majority is against physician-assisted dying for severe and persistent mental illness patients. So it brings us to question number 4. Patient C carried a diagnosis of schizophrenia, and what other psychiatric conditions may benefit from a palliative approach to treatment when it's proven futile? So schizophrenia, data shows 10 to 30% show little to no response to antipsychotic treatment and to ECT. This article titled Schizophrenia When Clozapine Fails. This is the World Journal of Biological Society guidelines for treatment of schizophrenia. And then similarly for major depression, 20 to 30% fail to respond to several steps of adequate treatment trials. Severe and persistent anorexia nervosa as well has been discussed as being a possible indication for palliative psychiatry. And this is back to the Swiss psychiatrist data asking a palliative approach would be suitable for severe, chronic, and therapy refractory, and then they break it down to each of these different diagnoses. And really the response is essentially the same for all of them, with the majority of Swiss psychiatrists saying they agree to a palliative model, with several saying strongly agree. US psychiatrists, perhaps a little bit more split, although the majority agreeing with the previous data, the majority agreeing that a palliative approach would be suitable for these 5 diagnoses, although, perhaps less strongly agreeing than it seems the Swiss psychiatrists. So we'll briefly discuss some barriers to this approach. And this is very generally speaking, but the traditional mindset in psychiatry may be a barrier itself. So there's widespread lack of interest in end-of-life issues, generally speaking, a widespread lack of interest in somatic illnesses. And there are only a few palliative care psychiatrists worldwide. So there isn't a large community to ask questions or to discuss this. As we discussed, there's no real consensus with regard to futility as it applies to psychiatric patients. And there's a lack of culture of end-of-life discussion within this field. And interestingly, the issue of suicide is frequently discussed in our field. And the conventional model is that prevention is the traditional main goal. However, death and dying in the wider sense is not a typical discussion, and hence there's not much literature on this matter. So next, here are some references. Briefly, just wanted to say thank you to all of my colleagues and my co-residents and everyone at the training office. I can't believe the 4 years have gone by so fast. And thank you for listening today. If anybody has any questions, I'd really love to hear people's opinions on this matter. I know it can be fairly divisive and people have kind of strongly held opinions. So I'd be very interested to hear what people have to say. So thank you.
Well, if I can jump in, thank you, Anna, for a very great and thorough overview and for bringing that into psychiatry. Those of us who operate in both the psychosomatic consult liaison world and psychiatry really think of palliative care as any age, any stage for anybody with any type of chronic illness. So anybody that needs that extra layer of support. And wouldn't that be wonderful if we could start earlier in the treatment of folks who we know are going to have a devastating medical illness that may have uncertain outcomes and uncertain responses to treatment. And the other comment that I had is general, and Dr. Lippman was probably familiar with this, but general sedation was commonly used in the early 80s. If you keep in mind, we only had the first generation antipsychotics and the MAOIs and tricyclics. A lot of time on an inpatient unit, we would put people in barbituric coma for 24 to 48 hours to see if that would break their agitation and psychosis, and it often did. And it kind of look at when there's futile treatment, usually what we think is you have the option to opt out. And, I think this brings up numerous topics for discussion to look at various applications in psychiatry. And I congratulate you on taking this very challenging topic on.
Thank you, Dr. Davis. So I see Rena, I know she's in the airport. She's traveling back from APA. So I'll just quickly read what she wrote. She said, in the airport, so I won't turn my mic on, but I wanted to thank you for your eloquently, thank you, Rena, organized grand rounds on a really compelling topic. I think psychiatrists in general are palliation minded on the most basic level, since we see chronic and often progressive illnesses and work to reduce suffering along the illness course. My question is about the ideas for staging of psychiatric illnesses. Did the paper you mentioned discuss how they determine criteria for each stage? It seems clear that psych staging will necessarily be fairly subjective versus staging of somatic illnesses, which is not inherently bad, but might affect outside perceptions about this approach. I'm curious specifically about how an approach to staging might or might not rely on things like the DSM or other contentious definitions of psych illnesses. And what would your opinion be on subjectivity in staging, or on the need for staging to justify a palliative approach? Yeah, so that's a great question. I think, I don't know specifically how they arrived at those staging models, but I think, in psychiatry, we have to be fairly comfortable with the subjective nature and, trust our colleagues and trust ourselves. A lot of times there are no black and white answers. So yeah, I agree. It's much less straightforward than in other somatic illnesses. a good point.
I've got a comment. Is that okay?
Yes, please.
Well, the first thing, our psychiatric patients are at a bigger disadvantage than all the rest of them because when they arrive in the ER after an overdose or whatever it is, they're not decisional often.
Right.
So they are not allowed to make the decisions that everybody else makes. The other thing is whenever you talk about palliative psychiatry, you have to include telling a patient, not physician-assisted suicide, quit eating and drinking when you're ready to go, period. There's no, family's not doing it to you, you're not doing it to them. They can change their mind every 15 minutes.
Mm-hmm.
I've had a fair amount of experience with that technique, and it is very effective. And if you take an elderly old person, it doesn't take long, and people in my age bracket don't perceive thirst. They don't feel hungry and thirsty.
Mm-hmm.
So it's not unpleasant, and it's quick, and it's nobody doing it to you. You can change your mind at every step. The other thing, I have a little challenge for you. Supposing you've been treating a patient for 20 years, you've tried everything, he's in stage 4, he's doing terrible. You got 2 or 3 of our guys looking at him and they can't help you. He's going down the hill. So one day he tells you, one day when I'm really at the end of my rope, I'm going to take a massive overdose of acetaminophen. When I come to the ER, don't give me N-cysteine. So 2 years later, he arrives in the ER. He says, "This is it, honey. I've had it. Let me alone."
Yeah, I mean, well, that's tricky because he's involving a lot of other people rather than just himself or, his psychiatrist in the discussion. So I think that's the importance of advanced directives, of surrogate decision makers, of a larger culture of understanding of this topic. But as it is today, if that happened, I think he would definitely have to get treatment.
Well, you said advanced directive. So if somebody, I know how this works, having been around for 50 or so years. When you come with an old one, they say, "Oh, but he did that 2 years ago. I don't know. Is that valid today? Let's try his mom. Oh, they're dead. Let's try his sibling. Well, they're not answering the phone. And here you are. His levels are bad. He's going to die of liver failure."
Yeah, I mean, in a true palliative model like they have in Switzerland and Belgium and the Netherlands, he wouldn't have had to do something as questionable as taking a Tylenol overdose. He would have, had a discussion with his psychiatrist and perhaps been prescribed a medication to facilitate his death. So it wouldn't have been just kind of a, guess as to whether he would have succeeded.
Well, you said it was in the Netherlands, then it wouldn't be acetaminophen, it'd be paracetamol.
Oh, yeah, good point.
Well, thank you. You did great. But as an editor of the newsletter for the KPMA, we would love to have an article on palliative psychiatrist in our newsletter the next time.
All right. Thanks, Dr. Levin.
Let me know if you want to do it.
Okay.
Dr. Good has a question.
Sure. Anna, this was so amazing. It made me think about the way we conceptualize mental illness in general. So if you think about it, schizophrenia, which is essentially a developmental dementia, is neurodegenerative. So you undoubtedly have a stage 4 and an end stage in that model. But something like borderline personality disorder, how do you really know if it's end stage, or how would you even define that? Yeah. So I would be curious to know the patients that are applying for physician-assisted suicide in the European countries, what diagnoses do they typically hold? Like, do you have any data that shows that spread?
Yeah, so I believe right now the only qualifying diagnoses are schizophrenia, major depressive disorder, and anorexia nervosa, or I believe bulimia. But in the Netherlands, I think is much more liberal, and you could qualify just for having intractable pain. And there's a really interesting New Yorker article that I will send out, and it describes a woman with borderline personality disorder who was just miserable and suffering her entire life, who ended up, she was given physician-assisted suicide, and her family was extremely upset. It's fascinating because they didn't even call her family for collateral or anything. And the son just found out one day that she had died. It's really crazy. You know, we don't even discharge patients from EPS without calling and speaking to a family member. And in the Netherlands, a borderline patient was able to, you know, enter life independently. So it's quite the spectrum of, you know, patient autonomy versus benevolence and everything. So I think it's a really interesting article that kind of gets at what you're asking about. So I'll send that link out.
Dr. Kabir, I believe, is next.
Hey, really good job with the presentation. My partner is actually, she's going to be starting palliative fellowship in like a month. And so these are kind of some discussions that we have. I know one of our graduates, Dr. Zachary Sager, he's actually the PI at Harvard doing work with psilocybin for end-of-life care. I'm not sure if you talked about this because there was a behavioral response in the unit, but did you learn anything at the APA conference about using psychedelics in the palliative setting?
No, I actually don't know really anything about that, but that's a great topic. I'll kind of look into that. So thanks for pointing that out.
Piggybacking off of that, Ryan, I briefly read an article about the use of the utility of LSD in treating anxiety in terminally ill cancer patients. But it would be really interesting to hear more, Anna, about the use of psychedelics in, you know, palliative psychiatry.
Yeah.
Dr.
Yeah,
Stewart,
Yeah. Yes, sir.
did you have a comment?
No.
Oh, I'm sorry.
About what?
Anything? No. Okay, well, I'll get back to other folks to do.
Okay, go ahead.
All right.
Yeah.
Dr.
I thought it was
Ali?
it was a great presentation. It's really making me think about a lot of things. I'm not sure what to ask. I don't have a problem with the, you know,
Thank you,
so
Dr.
I'm enjoying the other questions. I mean, I certainly have a bit of a bristle in my around making anorexia and bulimia. I understand terminal. I mean, the assisted suicide, but I mean, I agree with everything that's been said about, you know, this is a very well put together presentation, and also a topic that is very timely. So thanks for doing this.
Yeah.
Well, Chris, I actually have used palliative care for an anorexia, and remember, it's any age, any stage.
I don't palliative would, I guess I had the problem with assisted suicide in that. I'm not saying it's wrong. It just, I was
but should that not be a criteria that they've had good palliative care before they become a candidate for assisted suicide? And we don't do that wraparound service in psychiatry. When you get a palliative care consult for a medical person, they get a chaplain, they get a social worker, they get a physician, they get an APRN, and they get connected to resources and services.
Yeah, got it. Yeah. Good points. Very good points.
Dr. Oliva.
Yeah, and I thought that was a great talk, honestly, especially the idea of staging and whatnot. I mean, I think it'll be difficult in psychiatry, obviously, because we're more of a qualitative profession this time, more rather than quantitative. But my thought is, you know, looking at the risks of this, palliative psychiatry, especially end of life or assisted suicide in psychiatry, is the risk of eugenics, right? Is you know, it has to be a very well regulated system so that people who are vulnerable aren't being abused by either the healthcare system or the state to do and being put to death. One thing I was reading while you're doing this talk was in Canada, at least when this assisted death program is being rolled out, is when this was being rolled out, that the Canadian doctors are actually being encouraged to bring up assisted suicide with patients rather than some European countries where they wait for the patient to bring it up themselves or patient's family members. Which I think that's a good rule, because you don't want someone to feel pressure. Say someone with terminal illness who might already be feeling like a burden, it has to be their decision. They shouldn't feel pressured in that situation. So I definitely think that's one aspect to be thought of.
Yeah, absolutely. I agree. I think there's, you definitely don't want someone to feel pressured, but at the same time, it's important for patients to know all the options that are in front of them. Hopefully, the physician could lay them all out in a neutral way and let the patient and family make their decisions.
Dr. Good?
I think that might be an old,
Did you have another question?
I had a question that was, this is Ariel.
Okay.
I had a question that kind of piggybacks off of what Art had said. It was more of like a question comment. Firstly, Anna, thank you so much for your fantastic presentation. It's really something we don't talk about as much as we should, and it's something we should think about much more often than we do. As I said, I've got somewhat of a comment question in discussing not only discussing choosing palliative care, but also making it an advanced directive related to end-of-life psychiatric care. When people discuss with somatic diseases, discuss palliative care, especially early on in the patient's, when the patient first receives a terminal diagnosis, it's a discussion that both the patient and the family can engage in. However, and of course the patient, as long as they're decisional, can cooperate and be involved heavily in that discussion. I wonder how you reconcile the fact that even early on in the diagnosis, when you'd be having a discussion about advanced care, hopelessness related to the diagnosis and suicidal thoughts are an integral part of a diagnosis that may eventually turn terminal. So I guess, how does a patient who has those symptoms as part of their diagnosis, how can they engage in a discussion about palliative care early on? You know what I mean?
That's a really, really interesting point. I think that part of that kind of alludes to, our cultural understanding of death and dying. In many ways, I think that the introduction or the offering of palliative care can be actually hopeful in itself. For the patient to know that they have options, they have choices. It can reinstate a sense of agency, a sense of control in a situation where they feel like they have little control, and improved quality of life. So I see what you're saying about kind of, it almost seems like you're telling the patient, like, oh, we have to move to palliative care. There's no hope for you. Things, look bleak. At the same time, I think it's actually, in practice, people find a lot of comfort and support from the palliative model. So, but yeah, that's a good question. I think it's a unique to our patient population. Does that actually prove to be true? So I think that's a really good observation.
Just going off on that, this is Dr. Ife. Just going off on that, it'd be interesting to come up with a system with the mental disorders that do progress to a stage where people can essentially not make good decisions for themselves. Schizophrenia obviously comes to mind. When you first diagnose schizophrenia, is there a way for us to have a document or something legal in place that the patient and their family, while they're still young and can make some decisions for themselves, what happens when you progress and you're no longer lucid and can't make those decisions? Because what I'm seeing in your discussion is with the stages of the mental illness, you have disorders that obviously those people are not going to recover from, like schizophrenia or maybe severe dementia, but they don't possess the lucid ability to make their own decisions. And then you have disorders where maybe a little bit more questionable if there is any type of recovery available, such as major depressive disorder, but they are lucid to make their decisions. So it'd be interesting, like in the ones where you lose that ability to come up with something earlier on. Although Dr. Lippman brought up that advanced directives aren't always listened to, but to come up with something early on when they can't actually make decisions for themselves.
Although I would caution that that could have a prominent negative placebo effect on the patient.
Perhaps, but kind of, perhaps, Dr. Shanebachler, but, you know, I think the idea of agency and control in one's destiny, I think can be really empowering. So.
Well, just to use an analogy, if you had a colon polyp and you go back for your follow-up and they ask you about, you know, whether or not you want to be DNR if this progresses to full cancer, would create a lot of angst. And with schizophrenics in particular, you're really having to work hard to get them on board with treatment to start with, and optimism and hope are a critical part of establishing a therapeutic alliance. So I think you know, obviously the problem with this is that there's a sliding scale of, you know, towards palliation as per your slide, where you have that, you know, the triangle cut in there, where as you progress, it becomes more important. And while you do want to probably, you know, ethically, you're supposed to act the way that the patient would choose to do so in this situation, had they had the decisional capacity and at their peak function. And so you don't want to wait too late, but I do think that you have to make sure that you've got a solid therapeutic alliance, and before it's even, you know, broached with most of these psychiatric conditions.
Yeah, absolutely. Agree.
Dr. Faruqi has a comment, I believe.
Yeah, I sorry for missing a good chunk of the presentation, but I have more of a philosophical question, actually. You know, so if you conceptualize palliative care, then it's essentially symptomatic treatment, right? So which is separate from end of life care, right? So end of life care, palliative care are not the same. And would it be worthwhile to adjust the mindset? And maybe this is what you've already covered. I wasn't sure, but it would be worthwhile to address the entire spectrum, or most of the spectrum of psychiatric care, as palliative in some kind of capacity. Because ultimately speaking, I mean, recent fMRI data suggests that even the prefrontal cortex problems that you see in depression is actually an incomplete brain compensatory response rather than the actual pathology, right? So we are essentially managing symptoms. And if you look at the APA talks recently, they're focusing on, you know, think symptoms and not synapses, you know, symptoms in circuits and nodes and networks, et cetera. So would it be worthwhile to adjust, based on your research, our mindsets in treating our patients as, to a certain degree, palliative from the very start of a diagnosis, not necessarily at the end of a diagnosis?
Yeah, I mean, I touched on that a little bit, but yeah, I think you could definitely argue that our entire field is a form of palliative care. I think that would be very accurate. Yeah, Dr. Kalil, did you have something?
Yeah, there was a case that a patient I was doing ECT with many years ago here at U of L, and looking back at it, you can argue that it was palliative. There's a gentleman in his 70s, and he had a long history of depression, and he and the family agreed to do ECT with him as a maintenance, because without the ECT, he would be forced to be living in a nursing home. And for him, nursing home is the same thing as death. And you know, ECT in his case helped with the symptoms. It wasn't a treatment, it wasn't a cure, obviously. So he did this for quite a while, so that it was really more for quality of life. So we were treating his symptoms. He wasn't really responsive to medications. He had a lot of medical issues. And so he was very persistent that we do this ECT for quite a bit of time. It was, I mean, looking back at it, we didn't use the word palliative at that time, but you know, essentially it was almost like palliative ECT. We were allowing him to helping him treat his symptoms so that he could be at home with his family without being in a nursing home. And he eventually ended up dying, but he never went to a nursing home. So he was able to do that. So kind of brings up the question, can you use like treatments like TMS, ketamine, and other treatments like ECT for like palliative care to, obviously to reduce symptoms, but they're still, very symptomatic and treatment resistant, so to speak.
Yeah, I think especially, oh, go ahead.
Yeah, and on the kind of a flip side to this conversation, I still do think that a lot of medical teams out there here, especially at Norton, U of L, and I see this everywhere. I still think a lot of medical teams are still not able to recognize psychiatric illness in the elderly, and they tend to dismiss, like they quickly call palliative care, and so too quickly. To me, it's an easy way out for a lot of them, and I'm not blaming them necessarily. I think they just don't recognize comorbid psychiatric illness that's actually causing a lot of these medical problems. And an example of that would be maybe 4 or 5 years ago, I was covering for Dr. Wong at Norton's for an ECT. A couple families were irate that palliative care was called on their loved one who was medically hospitalized, and the families were saying they need to treat their depression first before they can go to palliative care. And Dr. Wong was actually out of the country. He was on vacation at the time, so they actually asked me to see these patients. And one patient ended up getting ECT and ended up going home. So it was a big change and shift in in terms of the outlook at that time. So in terms of what happened, and so I you still see this happen very often. There's so many patients who get discharged from the medical floor who go to a nursing home with untreated psychiatric illness. They end up dying at the nursing homes because of this illness. But it's it's labeled as a cardiac arrest or stroke or whatever. But the true cause is actually psychiatric illness. But so I think that still happens a lot, and that's the importance of psychiatric consultation. A lot of it has to do with getting patients out of the hospital too quickly and not recognizing how much psychiatric illness contributes to the medical presentation or worsening.
Yeah, absolutely. Thank you so much for that. I think that's a really good point to keep in mind.
Yeah, those are good points. I'm wondering, adopting palliative care in the psychiatric patients in America, is it going to be different than other countries because we're so litigation focused and we're so heavy on the insurance companies?
Yeah, I think America is definitely unique. I think it's tough to compare what we do here culturally and in the legal sense to a lot of what's going on in Europe. It's just so different.
Are there any more questions or comments from the group? Well, thank you for attending today and turning up on this APA week. And those of you who went to some rather extreme measures to get here, we do appreciate that. We'll be back next week, and have a good Memorial Day.